Hello and welcome to a new episode of Majlis podcast by Emirates Hospitals Group. My name is 𝗠𝗷𝗶𝘀 and I'm a family medicine consultant and I'm your host today. And it's a pleasure of mine to host Dr. Yasir, our intervention cardiologist, who's going to start our new year episodes talking about healthy heart, healthy lifestyle. Dr. Yasir.
Thank you, Dr. 𝗠𝗷𝗶𝘀. It's an honor and pleasure to meet you and our audience. And Happy New Year to you and all around people. I am Dr. Yasir Parviz. I'm UK board certified intervention cardiologist. I completed my training in a high volume academic centers in United Kingdom. And after that, I moved to Canada and I did a intervention fellowship in Western University in Canada. I decided to stay there in North America and I moved to New York and I did a postdoctoral research fellowship from Columbia University in New York. There I had opportunity to work with world-leading experts, opinion leaders, and I completed my PhD in the field of imaging and physiology. I have a keen interest in diabetes and chronic kidney disease and I have a master's degree as well as a doctorate in the field. I've been here in Dubai for the last 8 years and I worked in different institutes and it's an honor and privilege to join Emirates Hospitals Group as an intervention cardiologist and we look forward for an exciting new year.
Well, it's definitely a humbling experience sitting here actually listening to all your experience and I'm sure we're going to benefit our audience. So today, probably it's a bit more kind of specialized talk. We're not going to talk about basic preventive measures. We're going to talk about heart disease, blockage, and then try to help people understand what is the difference between different modalities, different techniques, and most importantly, that what can they do to make things better. So allow me by just going straight to the topic saying, tell me about the imaging techniques. How do we diagnose heart blockages?
Thank you very much. It's very, very common, Dr. 𝗠𝗷𝗶𝘀, people come to us and they say, how can I look into the blockages in the arteries of my heart? And in 2025, I can tell you that it's very easy that we can assess the arteries of the heart by simple imaging techniques. One of the simple techniques will be that we just do an imaging of the arteries of heart by doing a CT scan. What happens is, very simple test, easy, non-invasive, takes only an hour or so and you will be discharged on the same day. We inject some dye or a contrast into one of your veins and we take the images of these arteries. And to be honest, this test is so good now that the sensitivity of this test is more than 90%. And we can tell you with a very high predictivity that whether you have a blockages or not. And these techniques are so good in comparison to many of the other traditional non-invasive investigations like an exercise treadmill test. And as an expert, I believe that this is the modality that people should be aware that a CT scan or a calcium scoring should be done to look into the arteries. And I'll just go a little further that as an intervention cardiologist, what I do is I don't only look at the images for diagnosing. What we do is that we can plan these CT images and decide before taking someone into the cath lab and decide whether he needs what sort of tools, gadgets. We can plan whole procedure, even sitting in the clinic and decide what will be the outcome. So I really believe one of the common thing that we can do now is just do a CT calcium score and a CT angiogram to look into the blockages.
It's amazing. And honestly, thank you for this. And this is what I try to encourage my patients to do it because now we can catch things early. It's really like if
you're right.
any minor work on the arteries, what I call it, I compare it with the street. So like if there's a road work that's starting to happen. So now we can catch those early things very early, which we could have missed on the stress test before.
You're absolutely right. And if we talk in the medical term, the sensitivity of a treadmill test is about 67%.
Oh, wow.
It's like switching the coin, like 1/3 of the people, it might give you wrong information. So one of the common or simple tests might be just do a CT scan and it will give you a lot of information.
So you mentioned the CT and then you mentioned that there are one with dye and one calcium score that you mentioned. Do you mind telling me like the types of the imaging that we commonly use and I mean, how does it work? How do you use it to assess the heart blockage and how do they differ in terms of their predictability, their accuracy, and most importantly, what happens afterwards?
Thank you. So as we want to strive for the better for our patients, so as I mentioned, that one of the technique is just do a CT scan or do a CT angiography. You know, when I take someone into the cath lab, we have a lot of techniques inside the cath lab, the imaging techniques, where I can see the artery from inside. So as you mentioned, that we don't want the road to get messed up or blocked. An artery is just like a tire. It has 3 layers in it. So if I take someone into the cath lab, we have techniques inside where we can use a camera-based imaging techniques. And I'll give you a couple of names. That one is called IVUS. It's an intravascular ultrasound that we use inside the coronaries. Another technique is called OCT, optimal coherence tomography. Just like the way people do it for the eyes, you know, to look into the fundus, we can go inside the arteries and take the pictures. Think about this, that we used to use old gadgets and old phones. In 2025, you have new branded gadgets. Why don't you want your patients to have the precision medicine and exact? These imaging techniques can tell you, I can plan what will be the outcome of the procedure beforehand. So these sound-based or a light-based techniques can help us decide what sort of stents I need. I can plan beforehand and look into and see whether there is a lipid in the artery, there is a calcium in the artery, or there is a fibrous. And depending on that, I will decide my tools and techniques, and I will give an appropriate size of the stent. I will give the best possible length, and I can look into possible complications during or after the procedure. So in Emirates Hospital, as I said to you, that because of my training, we are a very high volume imaging center. So what we do is we do the imaging before the procedure and during the procedure as well. We have tools and techniques to give the best possible outcome for our patients at Emirates Hospital Group.
That's really fascinating, and this is basically what we always encourage people: is to personalize. We're not equal, and we cannot say things black or white.
Yeah.
And again, like I said, this is 2025. We're a new year, but also we need to practice 2025 medicine. We cannot keep relying on things that were even 5 years. Medicine keeps evolving.
Yeah, you're absolutely right.
So you mentioned that you go in, you have a look, and then you decide which stent is best.
Yeah.
What is stenting? Let's go basic. What's stenting?
So to be honest, that's a very important question, and I'm grateful that you're asking this, because people are very commonly saying, "Oh, what is a stent?" If I make it simple for you, it's just like a spring of a pen. It's nothing more than that. Basically, what happens is it's a wire-based hollow cylindrical tube. So when we go inside the artery, we see that there is a blockage. We unblock the blockage by balloon. And just to keep that artery patent or open, we use this very small device. This is called a stent. As an interventional cardiologist, just think about this. We are normally labeled as plumbers, that we look into the arteries. And
I was going to tease you and say that you're basically a sophisticated plumber. So thank you for saying that before.
Absolutely. Okay. So we are proud plumbers where we unblock the arteries of the body. So we can unblock from head to toe. So let's concentrate if we are thinking about coronaries. These are the small devices. When we have unblocked an artery, we put these devices there to keep the artery open. If we go back into the history of intervention, let's say we started the first intervention in 1977, in the last 3-4 decades, a lot of advancements have happened on the stents. Previously, we used to have what we call as a bare metal stent, where there was no medication on it. In the last 2-3 decades, we have now medicated stents where you have this metal, you have the spring, and then there is specific medicine on it. So it keeps the artery patent for a longer period of time. So basically, it's a simple spring that we put in somebody's artery, and it helps to keep the artery open.
And so it's medicated, coated with this medication. And when you say it lasts longer, what's the average? I know it differs from one person to another, but are we talking 2 years, 5 years on average?
Thank you. So very commonly, the patients are asking how long it's going to last. For us, as an interventionist, stents are for life. But we can't give you the exact duration, how long this is going to last. Because there are a lot of variables where we look into these stents and see whether the stent will block or not. In 2025, using the highly sophisticated imaging and physiology techniques, the problems with the stents are very, very uncommon. Okay, so we are just talking about 2 to 3% of the patients where you will have some sort of problems or narrowing with the arteries after the stenting, but the stents are there for life and they stay there for life. And I have to tell you, very commonly people ask us, oh, can I take the stent out?
Yes.
Unfortunately, no, you can't take the stent out. It stays a part of your body and it doesn't cause you problems.
Fair enough. Now, you are an interventional cardiologist, but also you're a cardiologist, and your job is not to put stents. So how do you decide when a stent is needed and when is the stent not needed?
Thank you. So not every blockage needs a stent. This was my message before, and this is what we want to advocate as well, that we want to give what is the best possible treatment for an individual. As I was saying to you, that the artery is like a tire. It has 3 layers. So if I take a patient into the cath lab and I have a doubt that the blockage is not severe, in my practice, and it's been evidenced in the last 8 years here, as well as where we worked before in New York or in Canada, we have a lot of sophisticated techniques where we have a pressure flow measurements. We just don't go inside the artery, look at the blockage and put a stent. We believe that we need to individualize and see whether this blockage is causing harm to an individual. It is causing a problem to an individual. So we have what we call as a pressure flow measurements or a fractional flow reserve wire or computerized based technique where we measure the pressure before and after the blockage. Okay, so if you allow me that, let's say there is a blockage, this technique, the wire, will allow me to measure the pressure before and after, and I will check this river that is flowing, whether there is a flow impairment or not. And depending on that particular patient, if the flow is impaired and it's affecting or causing, in medical term, ischemia, then you will need a stent. Most of our patients, when they come to the cath lab, I always talk to them in the clinic that not every blockage needs a stent. There are a lot of other options. Let's say we do an angiogram and your assessment shows us that the blockage is not bad. It is only, let's say, 10%, 20%, or 30%. We'll just give you our wonderful, simple medicines like statins or an aspirin. And we'll ask your help as a medical expert to manage the lifestyle and look into it. So yes, not every blockage needs a stent.
And that's very interesting, actually, and thank you. And I always use these opportunities as well to learn and evolve as a doctor. So thank you, I mean, for teaching me today and as well as our audience. I mean, in the past, during training, it used to be like a black and white, saying that 70% and above stenting, and then you reach certain number, they talk about bypass surgery. Is that still the case?
Thank you. So, of course, interventional cardiology is an opinion-based, and it's one of the most advanced specialty, if you allow me, where all the advancement and research is happening. Not every blockage needs a stent. If your blockage is 70%, but if it's not causing you ischemia, if the artery is small and it is supplying that territory that is infarcted, where the muscle is dead, if you do this fractional flow reserve or a measurement, and if it is negative, putting a stent will not help the patient. Okay, so you will unblock the artery, but it will not help the patient. So not every 60% or 70% blockage is important for the patient as well. At the same time, we have to tell people that stents are very useful and they are helpful. And current era, what we are doing is what we call as a complex, high-risk indicated procedures that we treat in our practice a lot of patients where they're not suitable for bypass. So they're not fit for bypass. They have a lot of comorbidities. They have kidney problems. They have diabetes. And they consent that they don't want to go for bypass. Intervention or stent is one of the options. Let's say a patient who already has a bypass and his bypass fails. So one of the options for you is just do the stenting. Think about our dynamic population in Dubai, where the people want to go back to work and they want to have a quick recovery.
Absolutely.
Stenting is one of the best options for you. So it's the right patient, right doctor, right decision, and teamwork. And in Emirates Hospital Group, we have the MDT and discussion approach where we decide what you need and what you deserve.
And for sure, we have the expertise actually with doctors like yourself. And
Thank
it's
you.
really fascinating because I couldn't agree more. This specialty has been evolving a lot since I became a doctor 18 years ago. And I think you're taking away a lot of what you refer to as bypass, which is basically the open heart surgery, as we commonly call it. So I think this is why, if I'm not mistaken, the number of open heart surgeries is definitely decreasing worldwide. Is that correct?
Yeah, absolutely. So we are not saying that people don't need surgery.
Of course.
It's important.
Of course.
What we need is we need the right treatment for a right patient.
Yeah.
So as a surgeon, we have a lot of patients where we have to ask for an opinion from a surgeon, and we have to give the best possible outcome for a patient, and we should have a discussion as a team. Surgeons agree as well that minimal invasive procedures or a keyhole surgery is advancing, as you can see in other fields as well, in cosmetics. So here, we are doing a procedure that is just through a small wrist. It's like a small mosquito bite. Our wristband, patient stays in the hospital for 4 or 5 hours, and then he goes home, and after 2-3 days, he goes back to work. So these are few of the things that we want to highlight. Not every patient needs a stent. Not every patient needs a bypass as well. They need an individualized, personalized care that is right for them. So as an interventionist, we always have this collaborative discussion with our surgeons. And we are lucky enough in this city that we have the top surgeons as well as interventional cardiologists that can provide the best care to the patient.
And exactly. And I mean, that's what you refer to as the MDT. At the end of the day, we're here to do the best for every patient, every person.
Absolutely.
Dr. Yasir, I mean, it's a pleasure. I could keep you here. I could ask. Now I'm asking my own questions. So, and it's so exciting that maybe I'm considering changing my career. I'm not sure if it's too late for me, but has been a pleasure. Any last minute you want to tell our audience today?
No, we had a great discussion, Dr. Weil, and we need an expert like you to assess the patients. And as you know, that the leading cause of death all over the world is cardiovascular illness. The message I want to give is that not every blockage needs a stent, but at the same time, the people in Dubai, they deserve the best possible care. With imaging and physiology guided interventions, we will give you whether you need to unblock this artery or not. And when you are in the cath lab, we will give you the best possible outcome that you deserve in 2025. The Emirates Hospital Group has the facilities, the tools, the team that gives you the best possible outcome in the current era. And it was a pleasure chatting with you.
Thank you very much. This brings us to the end of today's episode. Thank you very much for listening. Stay tuned for our next episode coming soon. And for now, till now, please stay healthy and stay well.
Thank you.